Hello, and welcome to the Pediatric Anesthesia Podcast of the Month from Open Anesthesia, where we highlight an interesting image or clinical finding. My name is Devnath Chatterjee, and I'm a pediatric anesthesiologist at the Children's Hospital of Colorado. I do not have any financial disclosures. The clinical diagnosis for this month is laryngospasm. This is a video of a 6-month-old infant with biphasic stridor undergoing a diagnostic rigid bronchoscopy. As the bronchoscope is advanced towards the glottic opening, he develops complete laryngospasm with adduction of the vocal cords. You then hear the anesthesiologist calling out the diagnosis, and the bronchoscope is withdrawn.
The adductory function is good. Laryngospasm.
Laryngospasm is an infrequent but potentially life-threatening complication that typically occurs in children during induction and emergence from anesthesia. It is a physiological exaggeration of the protective glottic closure reflex and is characterized by sustained closure of the true and false vocal cords. Like most airway reflexes, laryngospasm is elicited by stimulation of the internal branch of the superior laryngeal nerve. During partial laryngospasm, both vocal cords are firmly pressed against each other, and there is a small gap posteriorly that allows minimal air entry. In contrast, during complete laryngospasm, in addition to the closure of the false vocal cords, there is apposition of the laryngeal surface of the epiglottis and the interarytenoids, which results in complete cessation of air movement and absence of enteral CO2 tracing. As mentioned previously, during partial laryngospasm, there is minimal air entry and chest movement with high-pitched inspiratory stridor, suprasternal and supraclavicular retractions, and flailing of the lower ribs that results a rocking horse. There is minimal bag movement, and as the laryngospasm worsens, there is complete glottic closure and no air entry. The inspiratory effort becomes silent, which is an ominous sign. If not treated immediately, it results in oxygen desaturation and bradycardia. Interestingly, the ensuing hypoxia and hypercarbia decrease postsynaptic potentials and brainstem input to the superior laryngeal nerve, which results in less vigorous glottic closure and resolution of laryngospasm. Let us now discuss the incidence of laryngospasm. It occurs more commonly in young children than adults. The actual incidence of laryngospasm is difficult to determine as the working definition of laryngospasm used varies. The case mix is also different, and there is often underreporting of incidence. Olson et al. Quoted an incidence of about 1.7% with a higher incidence in younger patients. In contrast, Burgoyne et al. Reported a remarkably low incidence of 0.1% at a pediatric cancer hospital. Half of their laryngospasm episodes occurred during emergence from anesthesia or sedation, while the remainder were equally divided between induction and maintenance. Let us now discuss the risk factors for laryngospasm. The most important anesthesia-related risk factor is stimulation at an inappropriate depth of anesthesia. Common causes include extubation at a light plane of anesthesia, blood or secretions irritating the vocal cords, and stimulation of the airway by a laryngoscope or suction catheter. Volatile anesthetics have also been associated with an increased risk of laryngospasm. Among the volatile anesthetics, laryngospasm is seen more commonly with desflurane than iso or sevoflurane. There is some controversy in the literature regarding the type of airway used. While some studies suggest that the use of a cuffed endotracheal tube in children less than 4 years of age increases the risk of laryngospasm, other studies have shown that LMAs increase the risk. Similarly, multiple endotracheal tube and LMA insertion attempts increase the risk of laryngospasm. The role of the experience of the anesthesiologist remains controversial. Some authors suggest that laryngospasm is seen more commonly with inexperienced anesthesia care providers. The most important patient-related risk factor is young age. Laryngospasm is seen more commonly in infants and children less than 2 years of age. A recent URI within the last 2 weeks increases the risk from 2.3 to 5-fold. Similarly, children with reactive airway disease and asthma are 10 times more prone to develop laryngospasm. Other risk factors include ASA4 patients, ex-premature infants, children with OSA, and reflux. Finally, patients with an elongated uvula and those with a history of choking during sleep may also develop laryngospasm under general anesthesia. Among surgeries, shared airway procedures such as bronchoscopy and TNAs have the highest incidence. TNAs have an incidence of about 21 to 26%. Other surgeries that increase the risk are appendectomy, cervical dilatation, and hypospadias repair. Thyroid surgery increases the risk secondary to the supralaryngeal nerve injury, and esophageal endoscopy may cause laryngospasm secondary to stimulation of distal afferent esophageal nerves. Identifying patients at risk for laryngospasm and taking necessary precautions is critical. During the preoperative evaluation, presence of URI symptoms and secondhand smoke exposure must be questioned. The optimal time to delay anesthesia in children with a URI is an ongoing debate. It may take up to 6 to 8 weeks for airway reactivity to return to baseline. During induction, continuous monitoring of respirations and avoiding any painful stimulation or airway instrumentation during a light plane of anesthesia is recommended. As mentioned previously, laryngospasm occurs more frequently during emergence. There is no clear consensus on awake versus deep extubation. There are advantages and disadvantages with both techniques. However, during awake extubation, the patient should demonstrate full recovery of airway reflexes, including facial grimacing, coughing with the mouth open, and eye opening. The role of intravenous or topical lidocaine in preventing laryngospasm is controversial. As soon as laryngospasm is recognized, a voice of command must be used to declare an emergency and call for help. A tight-fitting face mask should be used to apply CPAP with 100% oxygen. As part of the initial treatment, a vigorous jaw thrust must be applied using 2 hands if necessary to lift the epiglottis and tongue off the glottic opening. It also rocks the larynx forward and pulls the aryepiglottic folds, opening a small gap between the vocal cords. A jaw thrust also stimulates the patient as it's very painful. It is important to avoid vigorous attempts at ventilation at this time, as it will only result in insufflation of the stomach. An alternative is the Larson's maneuver, which is bilateral firm digital pressure on the laryngospasm notch, which is located behind the posterior ramus of the mandible and anterior to the mastoid. If the triggering agent is blood or secretions, they must be suctioned out immediately. If the laryngospasm does not resolve, propofol 0.5 to 1 mg per kilo may be administered. Propofol alone has been reported to resolve laryngospasm in 75% of cases. However, propofol has not been studied in children less than 3 years of age. If there is no resolution with propofol, the next step is administration of succinylcholine, which is considered the gold standard for the treatment of laryngospasm. In addition to succinylcholine, atropine must also be administered to avoid succinylcholine-induced bradycardia. The IV dose of succinylcholine is typically 0.5 to 2 milligrams per kilo. The successful use of a lower 0.1 milligram per kilo dose has also been reported to preserve spontaneous ventilation and break laryngospasm. If intravenous access is not available, succinylcholine may be administered intramuscularly. The IM dose of succinylcholine is 3 to 4 milligrams per kilo, and it may take up to 45 seconds to break laryngospasm. Other options for succinylcholine choline administration are intralingual and intraosseous administration. Intralingual injection is essentially an IM injection into the body of the tongue, and the dose is 2 milligrams per kilo. The dosage for intraosseous administration is 1 milligram per kilo. If succinylcholine is contraindicated, IV or IM rocuronium may also be administered. After laryngospasm has been treated, positive pressure ventilation with CPAP must be maintained until the patient starts breathing spontaneously. To summarize, laryngospasm is an infrequent but potentially life-threatening complication that typically occurs in young children during induction and emergence from anesthesia. It is a physiological exaggeration of the protective glottic closure reflex and is characterized by sustained closure of the true and the false vocal cords. Identifying patients at risk for laryngospasm and taking necessary precautions is critical. The most important anesthesia-related risk factor is stimulation at an inappropriate depth of anesthesia. Common causes include extubation at the light plane of anesthesia, blood or secretions irritating the vocal cords, and stimulation of the airway by a laryngoscope or suction catheter. The most important patient-related risk factor is young age and a recent URI. Among surgeries, shared airway procedures such as bronchoscopy and TNA have the highest incidence. Prompt recognition and treatment is critical. Thank you for watching this podcast.